Cobb Law Library. Thank you for coming and attending this program. You're welcome. Please sit anywhere you would like. The Cobb Law Library is a legal research facility for anyone in Cobb County. And our speaker today is Daniel Munster, and his law practice is the Elder Care and Special Needs practice. And he is going to speak on long-term care financing solutions, and I'm thrilled to have him.
Well, I'm glad to be here. This is kind of, I think, a new speaker series, so I'm glad to be kind of the beginning of something big, and hopefully you guys will come to more of those presentations in the future as well.
Absolutely. I'll turn it over to you.
Well, thank you for everybody being here. I know it's a little bit different being out and in the world and around other people, so for me it's nice to actually do that because for 2 years it hasn't been that way. The presentation that you guys have here is kind of a compilation of several that I typically do for other attorneys and financial planners and accountants. So hopefully you'll find it helpful and it's not too, legalese. Because we're a small group, I would love for anybody at any time to just hop in and ask a question or interact, make it more interactive rather than speech per se. Yes, sir.
Is there going to be any kind of handout then, or just, okay?
Oh,
There-
I'm not saying yes, I was agreeing with you.
So the handout is the presentation, and if
Okay.
you want to print that, you can. But there's not actually a hard copy of a
Okay.
handout, other than I have a business card if you want one. I do these community educations to share information. I'm not a very good marketing person. I actually have firm brochures and materials that I didn't bring because I forgot that I'm supposed to be doing that. But obviously my contact information is available. I'm happy to give you a card when we're done if you have follow-up questions. The way I'm a solo practitioner, and so I have the luxury of doing things how I like, which is to say that instead of just scheduling appointments blindly with folks, I like to gather enough information to figure out if whoever's calling actually needs what I do, as opposed to a traditional estate planning attorney or a tax lawyer or a financial planner or a geriatric psychiatrist. I mean, I've been practicing now for almost 30 years, and during all those years I've had the luxury of building relationships. So I'm sort of the spoke or the hub of a wagon wheel. I know lots of people who might need what you do, even if it isn't me, and I'm happy to try and make those connections if it's not me. And the time it takes to evaluate that, there's no fee for that time. So I'm glad to try and respond if there are questions. So obviously the program today is not about other areas of elder law, which might be probate or guardianship or Social Security disability benefits or even Medicare consulting. There's all kinds of things that fall under the umbrella of elder law or elder care. But today what I thought would be helpful to talk about, because frankly when I do a session that covers all that, all the questions at the end are laser focused on this topic. So it seems like there's a great deal of interest, and that's why I proposed to Kim that I just spend my time on this as opposed to all of that other stuff. Ms. Kim, how long am I speaking?
30, 45 minutes.
Okay, I was going to say I can go shorter or longer based on, I'm also happy to stick around for questions, but I'll try and keep it to less than 45 minutes.
We close at 5, so.
I can't go for 7 hours, no ma'am. So the first question is, what is long-term care? And I put that up there as to contrast it with actual health care or medical care and what Medicare will cover. So long-term care is non-medical, meaning doctors and nurses and licensed therapists. That's health care. So you can have home health care, you can have medical care in an outpatient doctor office, obviously in the hospital. But long-term care is not that. Long-term care is what you might call custodial in nature. And as you begin to learn more about this area, you'll hear the acronym ADL, Activities of Daily Living. And so as we all get older, and our either our cognitive limitations or physical limitations begin to impact our lifestyle, the things that we start to lose independence with include dressing, bathing, toileting, transferring, and feeding. Those are all pretty self-explanatory, except maybe transferring. Transferring is getting out of the chair you're sitting in, getting out of your bed, getting off the toilet, which technically comes under toileting too. But the point is, these are things we kind of take for granted right now, but at some point, if we have trouble with balance or with strength, there are times when we need help with these things. And so often, if any of you have any long-term care insurance, that insurance is triggered by your lack of independence or your inability to perform a certain number of those activities of daily living. And so as we lose independence, or as a loved one loses independence, the care that they might need is not inexpensive. And so the focus of today's discussion is if we ever do need that kind of help, what does it cost, and how do we finance that cost? In addition to, I don't know, can everybody read this, or is it too small? I can't really make it any bigger. I suppose I could move the TV closer to you. So dressing, bathing, toileting, transferring, feeding, also medication management, and the last couple, transportation, which is mainly getting to and from doctor office visits, also laundry, grocery shopping, meal preparation, housekeeping, and then statistically 70% of people who reach age 65 ultimately need long-term care. And so when you factor that into a couple, you've got two people, a husband and wife, each of which has a 70% chance post-65. What ends up, the reality is usually at least one spouse and potentially two ultimately need long-term care, as opposed to what we all hope for but kind of never happens, which is we just live our life perfectly independent for many, many years, and then at somewhere around 94 we die peacefully in our sleep without having ever faced any limitations. That really doesn't happen. And so that's why we're here to talk about accounting for the possibility that somebody might need expensive long-term care. So the next topic to focus on is, where is long-term care available? And so the first bullet point, 347 of 359 nursing homes in Georgia, memory care, assisted living facilities, personal care homes, independent living facilities, and private residences. I probably should do those in reverse order, but long-term care is basically available anywhere. You can pay for private in-home care. Georgia has a Medicaid program that I'll be touching on today that can provide assistance with in-home care. Independent living facilities are, for lack of a better phrase, glorified apartment complexes where there's an age requirement and a meal plan, and usually a social director. They can be a great option, especially if they are paired with an assisted living facility or a continuing care retirement center where you can transition from levels of care. Continuing care retirement center is an actual term of art, in the sense that there are places which have those different levels of care but are not CCRCs, and then those which are have typically a fairly substantial buy-in, meaning hundreds of thousands of dollars that you have to pay for the right to go there, and then pay rent, which is actually about the same as what you would pay at a very nice assisted living facility. So, most of my clients aren't in the level of society where they can afford $500,000 just to move in, and then the rent as well. If you can, they can be a great option. The buy-in has a component of it which allows for a refund depending on when you move out or when you pass away. The fine print of those provisions are something that typically a contract lawyer should review for you, because buried in the fine print there are often restrictions related to when they have to give you a refund, And there's been quite a bit of litigation around the country surrounding this idea that, well, we have to, for example, release your exact unit. So we have a bunch of other ones which in our new community have never been lived in. We're going to lease those and leave yours empty, and your family can't have your refund back until we reach maximum occupancy, which is not really the spirit of the rule, but the technical rule. So they can be a little tricky. Be careful about that. One of the other things I'd like to highlight is the difference between assisted living and memory care assisted living, and the fact that neither of those are nursing care. For some reason, it's just people think that memory care assisted living is above assisted living, and what's above assisted living is nursing care, so memory care assisted living must be nursing care. That's not correct. Why that's relevant is it directly impacts the different ways that something might be financed, more specifically Medicaid. So as we're going to be talking about today, whether you or I or we like it or not, Medicaid is the de facto long-term care insurance program of the country because so few people can afford the cost of actual long-term care out of pocket or have long-term care insurance because it's a fairly new animal, if you will. And so understanding what Medicaid will pay for and where it will provide assistance is a big deal, which is one of several of the myths that I'd like to talk about related to financing long-term care. Another is that you have to be destitute to ever get help from Medicaid, which is not true. And another is that you have to, or if you do ever get help from Medicaid, that your care will be deficient, which I'll be talking about. So memory care assisted living is not nursing care. There is no Medicaid assistance for that. And that's just purely private pay. From a practical standpoint, what is it? It's essentially assisted living, which is assistance with all those ADLs we talked about, within the confines of a floor or a wing of a care facility that has secure doors. And outside, usually they'll have a garden that's fenced with waterfalls and benches and windmills. I mean, I've seen some pretty amazing assisted living gardens and actually places where you can garden and grow things, but it's all secure. So someone can't wander off into the street or out into the woods and not remember how to get back. I guess now is a good time to address the topic of quality of care as it relates to Medicaid, and that is to highlight the statistic here. 347 of 359 of Georgia's nursing care facilities are dual certified. What that means is they are both a skilled nursing facility, which everybody seems to know that term because the acronym is a kind of a cool sounding SNF. So a SNF, but they're also intermediate level nursing care facilities. Intermediate level nursing care is what we're here to talk about. It is long-term care. We don't like the word nursing, just like we don't like the word geriatric and all kinds of other words that relate to this, but that's what we're talking about. Advanced custodial care. When somebody starts to need help with 2 or 3 or 4 or 5 of those activities of daily living, which doesn't even include medication management and grocery shopping and meal preparation and all that other stuff, at some point that becomes intermediate level nursing care. At the high end of assisted living, you cross into advanced custodial care, which qualifies in Georgia as intermediate level nursing care. And so there are folks who, from a medical level of care standpoint, who are straddling the line between assisted living and nursing care and which is appropriate for them. That can be a really difficult challenge for families because sometimes fate steps in and creates a need for move into nursing care, whether it be a fall or a stroke or a heart attack or something that is a bright line change in condition that leads to nursing care. That's not how it always plays out, though. Another way that it can play out is somebody is either at home with a spouse caring for them, or possibly widowed and in assisted living. And now you have to start thinking about, well, mom's 88, but her mom lived until 102, and she's only got $140,000 of savings left. How do we manage that? How do we stretch that? And when is the time from a logical standpoint for her to transition from assisted living into nursing care? And the common solution for that, which I don't actually agree with, and I'll explain that, is that most folks end up saying, well, what we'll do is we'll stretch that $140,000 as long as we can, and then if she outlives it in her assisted living facility that costs $6,000 a month, well, then we'll have to go to nursing care. Well, let's think about that for a second in light of the following rule. Nursing homes aren't all equal. There are good ones, there are average ones, and there are bad ones. They all are subject to the same law. That law says they get to pick who they want to do business with. And so if you roll up to the best nursing home around, your first choice, and you say, well, I'd like mom to move in, they'll smile and shake your hand and say, well, we're glad to give you a tour, and here's our admissions package. And oh, by the way, page 12 is our financial summary sheet. Make sure you complete that. They'll turn right to that before they look at anything else, because they'd like to know whether or not you are going to be a private pay admission or a Medicaid admission. This is a big deal because they don't get paid the same amount by everybody. Post-hospital rehab patients who come in under Medicare are where they make the highest revenue. Once somebody drops off skilled care that Medicare will help with, they drop onto long-term care, private pay. And then all the way at the bottom is the Medicaid long-term care. So by spending, going back to mom who's 88 in the nursing home with $140,000, by spending all of that before you have to cross the bridge to nursing care, what you're essentially choosing is to go to the good nursing home, knock on the door and say, may I please have a bed in your highly respected facility, but all I have to pay you with is your lowest rate of reimbursement. And the law says they're allowed to tell you bye-bye. And so this is a very important nugget of information, and that is that there can be times when it becomes clear that you're looking at that transition, that somebody is probably going to outlive their savings. There may be a reason to consider moving that person into nursing care before they're out of money, so that when you complete that admissions package that includes the financial summary sheet, you actually can put down something that represents a carrot to that admissions director, instead of just saying mom's broke and we have no way of paying you. That's not to say somebody should, it's a family decision. I don't know when the right time is. I'm just wanting to plant the seed that seeking a bed in the nursing home is not the same as going to Target or Walmart and buying whatever you want whenever you want it. These are highly coveted beds at the better facilities, and you have to factor this in as you go down that road.
Donna, as part of your practice, do you make recommendations to a person or persons regarding, once you understand their financial situation, do you make recommendations as to what type of facility to go to?
Good question. So for the tape, his question is, do I make recommendations to clients regarding the type of care facility they should go to, and within that genre, specific ones they might want to consider or not? And I'm pleased to say the answer is no. But what I do is I have built relationships with a variety of professionals out there whose title used to be geriatric care manager, but now is aging life care manager. They're typically RNs or LCSWs or MSWs, and their background is that. I'm not a doctor, I don't have medical training, I really don't have the ability, even though I have practical experience, to make those recommendations. And so I try to stay away from that. But I do have various resources where that is what they do. And they do it extremely well and thorough, and it's the best money you'll ever spend if you've got a family member facing this decision about when to leave home, where to go, what you can afford. This is different from the placement services that are out there. There are quite a few commission-based placement services which provide a valuable service, and yet 10% of the depth of knowledge and analysis goes into the recommendations they make. They're going to look at what part of town you live in, how much can you afford, and maybe a little bit about what mom or dad or your husband or whoever needs. They're not going to come out to your house. They're not going to look at any medical records. They're not going to communicate with any of your medical team that's taking care of you. The difference is that a private social worker that you hire will go as deep as you want and has, basically all the folks who I work with have many years of experience solving the riddle that you're currently trying to solve, kind of on your own. So I highly recommend the idea of a aging life care manager, and anybody who wants some names, email me and I'm happy to send them to you. So back to the last point about the 347 to 359. The point I'm trying to make there is if that number works out to 97%, by the way. So 97% of all Georgia's nursing homes take both Medicare, skilled care, and Medicaid long-term care. 97% means that there's a whole bunch of good ones, a whole bunch of average ones, and a whole bunch of bad ones that take Medicaid. That's a big deal, because what it means is that the question you need to answer is not, will my care suffer if I'm on Medicaid? The question is, how do I get a bed in one of the good nursing homes that also happens to take Medicaid? And you now understand the answer. The answer is, following a hospitalization, Medicare's 100 days of post-hospital rehab are the golden crowbar to get the door open basically anywhere you want. Next is private pay ability, and least is Medicaid. And so the fact that somebody goes into a good nursing home following a hospitalization through Medicare and then unfortunately doesn't rehab well enough to go home and has to stay there as a long-term care resident, the fact that they ultimately get assistance through Medicaid with the cost of that care has nothing to do with whether they're in a good nursing home and whether the care provided there is good. And the reason is that the law specifically says that the facility cannot have a Medicaid area, or these are the rooms where all the Medicaid people are, don't worry about them, caregivers. The caregivers on the halls aren't even allowed to know that Mrs. Jones in bed 221A is private pay and Mrs. Smith in bed 221B is on Medicaid, so that they can favor one or the other. They're just going out and doing their job caring for people. And so in my experience, which is 1,000+ families over 25+ years that I've helped navigate within the rules to qualify for Medicaid, not one family has ever come back to me and said, we regret having gone down that road to pursue Medicaid because care changed. So I just want to make sure nobody leaves with that idea that Medicaid equals bad care. Obviously, we'll spend some time on the other topic, which is I have to be destitute to ever get help from Medicaid, and therefore, why is this relevant? Well, you'll be surprised. Yes, ma'am.
I think I was told one time that once a patient is in a nursing home, they can't be thrown out because they have to go on Medicaid. Is that true or not true?
That is true. Again,
So once they get in there, they can't be thrown out.
For the purposes of the video, she's asking, is it true that the law says that if someone goes into a nursing home on a higher rate of reimbursement, namely Medicare or private pay, and later goes on Medicaid, can the nursing home retaliate or throw them out or do anything to them? And the answer is no. The law is actually clear that it's the opposite, and it says that they cannot retaliate when somebody goes on to Medicaid, And a condition of their participation in Medicaid, the contract they have with the state says they will not retaliate. And again, I've never had any, I mean, they can get hammered with fines and penalties and lose their certification. So I've never had a facility try to throw somebody out who qualified for Medicaid. And to give you some perspective, and I haven't looked at the statistic in a while, but the last time I did, there were somewhere between 40 and 50,000 people in nursing homes in Georgia, and the number was somewhere between 80 and 85% of those people were on Medicaid. So when I saw that, I remember being shocked because I thought Medicaid was for the bottom 5% or the poorest, when in reality, only the 15% wealthiest can actually afford $8,000, $9,000, $10,000 a month for care, if you think about it. Everyone else is either facing financial ruin or they have to find a way to navigate within Medicaid's rules. And so that's a big part of why I have a job, is helping people understand those rules, not break those rules, not violate those rules, not do things that are unethical. It's, if you think of it in terms of a football team that has an offensive playbook, the Medicaid code is my offensive playbook that I just teach my clients, and then they pick the plays they want to run. As long as we're running the plays in the playbook that they wrote, there's nothing improper with that. It's just smart. So back to why, to the idea that planning for long-term care is important. These are some numbers that will hopefully give you a sense of the cost that you might be looking at. Georgia on the left and the national on the right. And I think those numbers are, about right. We're in Metro Atlanta, so what you see for Georgia is a little bit low. The better nursing homes in Metro Atlanta are certainly 8,000 to 10,000. Assisted living, non-memory care, I'd probably say the floor is 3,000 for a inexpensive one, and easily 5 or 6 for the fancier ones, and even 7 or more for the ones if you want a waterfall in the lobby and a concierge that wears white gloves. But they exist. Memory care, now you're talking bigger numbers. So memory care, assisted living, the floor is going to be more like about $4,500 a month, and that's a great deal if you find that. It's typically about $5,000 to $7,000 a month for memory care, assisted living, and again, that's no Medicaid for that. That's just private pay. And then above that, starting at 7 and really more like 8 to 10 is private pay nursing care. So those of you who are retired and have 6-figure income, 100 grand or more a year, then you can go get a cup of coffee. You don't need to worry about the rest of this because you can just pay for your care by writing checks out of your income. For most of my clients, that's not an option. We're talking about people who have, a husband with $1,800 of Social Security and a wife who's got $1,100 of Social Security. Maybe there's a pension in there, but together they've got $3,000 or $4,000 a month of income coming in, and that's actually good for one of my clients. How are they supposed to afford numbers like this? And so, again, that's part of why we're here to learn more about this. If I touch this and move it up, will that result in it going up?
Yes, I believe it will.
Awesome. I almost said awesome sauce, which is, I've got a 4-year-old and a 6-year-old, and when they do something good, that's what I say, and they like it. So
A real technical person's taking over.
good, thank you.
There you go.
Oh, we're out of the,
Way to go.
we're in the view mode, which is better. Awesome. All right. So what are the options? What's the list for financing solutions? And the first thing you see there, Medicare, is crossed off. The reason is that Medicare was never designed to be long-term care insurance. There have been a couple of experiments with a national long-term care plan, but as of right now, there isn't one, and certainly Medicare is not that. Medicare and Medicaid sound alike, but they're, you guys probably remember the book, Men Are From Mars, Women Are From Venus, or it might be reversed. these are not even just same planets in the same solar system. They might as well be different solar systems. Medicare is national. There are only 4 types of Medicare. Part A is hospital coverage for the most part. Part B is outpatient doctor office visits and in-home physical therapy and so forth. Part D is prescription drugs. And then Part C is Advantage plans. Advantage plans are kind of the experiment with privatizing Medicare. Those of you who are on an Advantage plan, you should know that you're no longer on Medicare. A lot of times that's a little scary when people find that out. They think that it's a Medicare Advantage plan, so they're still on Medicare. You're not. Your Medicare is now ended, and you are just on a private insurance PPO plan that is designed to mirror Medicare. But in the experience of my clients and a lot of people in this aging community, the general consensus is that Advantage plans save you money from a cash flow standpoint, but even though they're designed to mirror Medicare, the reality is that you are not going to get the same care as a Medicare Advantage plan participant as opposed to traditional Medicare. And there are some reasons for that. First of all, and I don't want to get too sidetracked on this, the better, for example, the better skilled nursing facilities don't even participate in any Advantage plans. And so if you've got a hospital discharge plan or trying to place somebody in one of those facilities who's on an Advantage plan, it's not even on the list. Yes, sir.
Question I got. Medicare A is free. Medicare B I'm paying for.
That shocks me.
I get a Medicare Advantage plan through her retirement pension program. Why wouldn't that be covered?
Are you on the state health benefit plan or what?
I'm on the New Jersey State Health Benefit Plan. We relocated to New Jersey.
Okay. Well, then you're, what it used to be,
Because like I said, I'm still paying for B.
you're always going to pay the $170.10 a month. That's going to come out. A is free, he's right. Everybody pays at least $170.10 for Part B. If you're on an Advantage plan, that's not going to Medicare, that's going to Aetna or Humana or Kaiser. It still comes out. So from a cash flow standpoint, you don't achieve any benefit relative to that 170. But what you do accomplish is you don't have to have a Medicare supplement, which is anywhere from $200 to $300 a month. And you also don't need to have a Medicare Part D prescription drug plan, which is $40 to $70 a month. So per person, it's about $300 or $600 a month for a couple to be on an Advantage plan versus on traditional Medicare, plus a supplement, plus a Part D plan. So notwithstanding all of that, and the cash flow cost savings right now today, what I'm saying is that a lot of my clients have ultimately said, I regret going on an Advantage plan because I can't go to the doctors that I want and the care facilities that I want. And when I am in a skilled nursing facility, Medicare basically approves whatever the facility wants, but the insurance companies are super strict about the prior approvals, and they're going to terminate skilled care before Medicare would have, and it doesn't go as well. So this isn't a health insurance consulting time per se, but I do want to plant the seed that there are times when it can be appropriate for somebody to shift back to traditional Medicare, and that is possible. At the end of every year, there's a re-enrollment period if you choose. Before you do that, you should contact, there's an entity, write this down because it's not in the materials anywhere, called Georgia Cares in Georgia. The AgeWise, AGEWISE connection and Georgia Cares, they are a free Medicare consulting service. In addition to them, through the Atlanta Regional Commission, in addition to them, there are private Medicare consultants who can help you evaluate all this. Why I'm highlighting that is because Medicare supplemental insurance is not covered by the Affordable Care Act pre-existing condition rules. So trying to get normal health insurance, you can't be denied for pre-existing conditions. But trying to get a Medicare supplement, you can be. So somebody who's been on an Advantage plan and then their health declined, and then they want to go back to Medicare and get a supplement, it's possible they can't go back and get a supplement because their health changed and now they're not insurable.
Don,
Dan, yes, sir.
Dan, I'm sorry. Is this a state agency, Georgia Care?
It is not a state agency. It's run through the Atlanta Regional Commission, I believe. So it is a nonprofit. They don't make any money off of you. Their job is to help you. So I'm a fan of theirs. I'm happy to keep talking after 45 minutes, but I have 7 minutes left and we have like a lot more to talk about. So I'm going to call timeout on questions and let me pop through a few things. Private payment, we've talked about the cost of assisted living and nursing care. In home, I wanted to just mention briefly that at least post-COVID, you're looking at a minimum of $26 to $28 an hour for in-home unskilled companion care through a licensed, bonded, insured home care company. It is true that you could probably get your neighbor's niece who's in nursing school to work a few hours a day for $18 an hour or something. Again, the experience of my clients is that that normally doesn't go well. Aside from most people are breaking the law and paying that person under the table and not paying payroll taxes that are appropriately due, if that person gets sick or if that person goes on vacation, there's no backup for that. There's no background checks or credit checks, criminal background. So basically, there's a bunch of things that home care companies do to vet a person. They have a pool of vetted caregivers who've received training. Yes, you pay more, but they also handle the payroll taxes, and so that's all handled properly. And for all of that, you can pay $5 to $10 an hour more for care. It is more expensive, but in the end, you kind of get what you pay for. If you do the numbers, somewhere around 6 hours a day of care is when you cross into what it costs for a nice assisted living facility. So if a couple is at home and the healthy spouse can care for the spouse who needs help, or if she needs anything from up to 4 to, let's say, 6 hours a day, that's probably about, that's going to be less expensive than assisted living. But at some point, you're going to cross a line where it might be less expensive to move into assisted living, which, by the way, for a couple is not all that much more expensive than one person because they're both in the same space. It's really just the care bells and whistles that you add for the healthy person who probably doesn't even need any, and then meals. So, for example, if somebody's in an I've got a client right now who the husband had to go to a nursing home. They had been in assisted living that was costing them as a couple $6,000 a month, and her bill is going to go down to $5,000 a month now that he's not there. So it didn't go from 6 to 3 because it's only one person. It went from 6 to 5 because she's still taking up all that square footage of her unit. Long-term care insurance and hybrid investment products, those both have health underwriting. So just like you can't get homeowners insurance if the house is on fire, you can't get long-term care insurance or a hybrid investment product with a long-term care rider in circumstances where the person already has a medical condition that translates to future need for long-term care. So things, obviously any cognitive impairment issue like Alzheimer's or Parkinsonian's related dementia or any of those, diabetes, it's very difficult to get long-term care insurance the older you get because of all the health underwriting requirements. Having said that, I could do another 45 minutes just on long-term care insurance and whether it makes sense or not, and I guess we can't get too sidetracked on that. All I would say is talk to your financial professional to find out if it might be a good fit for you or for your family or for your loved ones. It isn't uncommon for a couple to have one person who's uninsurable, but at least we can get it for the second spouse, and that can actually be part of the Medicaid plan for that couple is the prepayment of insurance for her, which is, and I say her because typically my clients' wives are younger, the men are older, we're the weaker sex and, need help sooner and at younger ages, so you end up with a wife taking care of a husband. That's just how society has kind of worked things out. So I don't mean to throw men under the bus, but it's kind of usually that case. So it's typical for her to be able to be insurable, and let's say she's 68 and in good health, and he's 74 with Alzheimer's, and she's working her fingers to the bone taking care of him. We're here to talk about important stuff. So wiping his bottom, showering him, bathing him, dressing him, feeding him. She's being a nursing home for him, and at some point that is not, a human being is not capable of providing that 24/7. Spouses get together and they say in sickness and in health, but I've even told my wife, that doesn't mean you're a 24/7 slave to me when I need help later in life. So at some point it's important for families to talk about, before it's needed, what does that look like? Because unfortunately I've seen family dynamics change and relationships with children change because they didn't invest some time talking about what they think as a family regarding the timing of when these types of changes might need to be made. VA, aid and attendance, and Medicaid, whether it be Medicaid nursing home or the community care services program, are the remaining bullet points here. VA, aid and attendance is listed as that, but it's really part of the VA wartime pension. And so if you're here on behalf of a veteran or the widow of a veteran, then you should jot down the phrase VA wartime pension. If I ask for a show of hands, I bet a bunch of you have already heard of this thing called aid and attendance. Aid and attendance is the highest payment level of the wartime pension, which has 3 payment levels. And so the next bullet point, I believe, these amounts. Look at those numbers and imagine if you're the daughter of a widow of a veteran, or the daughter of a veteran whose wife has passed away, or a couple where there's a veteran involved. Those numbers are big enough. If you can see them, it's $1,318 a month, $2,050 a month, or $2,431 a month. Paycheck, cash from the VA that is used to finance in-home care or assisted living care. Those numbers are big enough to make a difference between affording a nice assisted living or not. So this is a need-based program, just like Medicaid is. The veteran had to have, actually let me backtrack. The first bullet point and the second, retirement and compensation. The VA pays out benefits on 3 tracks. If the veteran served at least 20 years, then there's just a retirement like he worked at Coca-Cola or any other company. Compensation is what they call it if you suffer a service-connected disability, whether it be a lost limb or vision or Agent Orange that leads to diabetes, all kinds of different things that can happen to those in service, then they're compensated. Those 2 checks are not need-based. So if you serve your 20 years, you get your retirement regardless of how many millions you inherit or you earn in a second career when you get out at 45. Same if you receive compensation, not need-based. The wartime pension with aid and attendance is need-based. In order to get help, you have to first, the veteran had to have served at least 90 days active duty, at least one of those days during wartime. If you have questions about what that is, Google VA periods of war, and there's a beginning and ending date of every single war in U.S. military history. This is especially important right now at this point in time because the first few years of the Vietnam War, which I'm starting to see people in that age range, that's the only time in U.S. military history there's a boots on the ground requirement. All of the other wars, as long as you were active duty in the military during the wartime, it didn't matter if you were in Kansas. You didn't have to be in a war theater and get shot at or suffer any injury. You just had to be active duty during that time. The only time in U.S. military history you actually had to be in the war zone is the first few years of the Vietnam War, which is basically the early 60s. And so make sure to double check that. As long as the veteran wasn't dishonorably discharged, then you're over those initial hurdles. That's when they start to look at the savings you have, the monthly income you have, and the medical bills that you have. So this is a program, you see the number there, $138,489, in addition to your home and a car. That's what they say that you're allowed to have and still qualify for this program. The VA's list of what's exempt is much, much shorter than Medicaid. So you do have to be fairly, if you want to call it destitute, to be under that limit. Once you are, they also will look at monthly income relative to medical expenses. So you might have $4,000 a month of income as a couple and be fine right now and not have medical bills that exceed your income. But what happens if you start to need in-home care or assisted living care? Very quickly, virtually instantly, you suddenly have medical bills because guess what? In-home care and assisted living rent count for purposes of this analysis. So you can quickly get over that threshold and qualify for those extra payments from the VA. Kim, I'm going to keep talking because there's still more, but if you want to cut me off at any point, folks seem interested. If you've got to be somewhere, feel free to walk out. I won't be offended, but I do want to talk a little bit more about, since we're just now kind of getting to Medicaid. Georgia, getting back to Medicare and Medicaid and how they differ, Medicare National, Medicaid is very state specific. 4 types of Medicare. Here in Georgia, our Medicaid program has 35 types of Medicaid. They don't all have the same eligibility criteria, and they obviously don't all provide the same benefits. So the question is, all right, that sounds crazy. How does that affect us? We're here to talk about long-term care. The answer is there are, for the most part, 2 types of the 35 types of Medicaid that are relevant. One is nursing home Medicaid, and one is this one, Georgia's Home and Community-Based Medicaid Program, more specifically, the Community Care Services Program. This is a program which up until a couple of years ago existed in theory, but was, for lack of a better word, defunct. The waiting list was so long to get help that by the time you applied for help in the home, which is when you needed the help, your loved one has gone down differently. Their care needs are so great that a year later, when you came up on the waiting list, the person was already deceased or needed a nursing home. So it really wasn't a very effective, helpful program. It's now being managed differently, it's being funded more, and so the waiting lists have gone away, and that's incredible. What this program is, first of all, it has eligibility criteria that match the nursing home class of assistance. So assets and income and transfer, all those rules that affect eligibility for nursing care are the exact same for this program. The theory behind this program is it costs the state, and this is just statistically, for one person to be in a nursing home, they can pay for 3.4 people to be at home where they would rather be. So why not fund that program more to create a situation where people can stay home where they would rather be and more people can get help for the same amount of money? And so now that's kind of happening. Those who qualify for this program, the acronym being CCSP, will typically be awarded 4 to 6 hours a day, 20 to 30 hours a week of help. If you crunch the numbers at $25 an hour, that comes in at the value of about $3,000 a month of care that's provided through CCSP. Depending on whether the person is married or single, there's a cost share, and I think I have a slide about that. So it may or may not be free, but it will be at a significant discount relative to what you would pay in the private pay market if you qualify for CCSP. The bullet points are much too small for anybody to read, so this program includes adult day health care, alternative living services, which is actually you can go and live in a personal care home, and Medicaid will help with the rent. Emergency response system, 24-hour access to medical services, home-delivered meals, home-delivered home health services and personal care support, and respite care. So this is a great program. It's something here in Metro Atlanta. The phone number, if you ever want to learn more about it, 404-463-3333. that is the phone number for the Atlanta Regional Commission line for people who want to get help through CCSP. You, 404-463-3333. You can also just Google Georgia Medicaid CCSP, and there's lots of information, or email me and I can email you the materials. But it's a wonderful program that has matching criteria to Georgia's nursing home program. So now we're going to talk about those quickly. These are the non-financial elements of qualifying for Medicaid. You have to be aged, blind, or disabled. Aged is over 65. And I actually have quite a few clients who are under 65 where we have to get a disability determination because they aren't yet on Medicare, they're not 65. Disabled, I always pause on that because just because, for example, someone's in a wheelchair doesn't mean they're disabled. Social Security defines disability by inability to work and earn a living. And so it's possible for someone in a wheelchair to have a job and make more than you or me. And so they actually look at earning potential when they define disability. You have to be a U.S. citizen, and you have to have a medical level of care, meaning you can't be financially within the rules and have nowhere to live and then go live in a Medicaid personal care home or assisted living facility, or nursing home when you don't have needs. There are a lot of people who meet those financial rules and don't have anywhere to live, but they can't just go and take up beds in nursing homes. So the first eligibility criteria is the monthly income, $2,523 a month. For someone who is married, that is a number that applies only to the person applying for Medicaid, and so not a couple. There are not brackets around the couple's total income. They're looking only at the person who needs help. So if the wife is caring for husband and his income is $2,700, well, then he's over the limit. But they're not looking at hers. The second bullet point, qualified income trust, that's for somebody who has income over the limit. Just because you have income over the limit doesn't mean you can't have help. Congress, this isn't Georgia, Congress created this concept of a qualified income trust, and for the sake of brevity, it's the tool that we use for people whose income exceeds $2,523 that Congress wanted us to be able to use. And the reason is, if your bill is $9,000 a month at the nursing home and your monthly income is $2,623 instead of $2,523, can you suddenly afford your $9,000 bill? No. And so they got that, and that's why they created this trust. Monthly income should not be a barrier to somebody qualifying for Medicaid in Georgia unless their income is so high it's actually more than the nursing home bill. If you have $7,000, $8,000, $9,000, $10,000 a month of income, well then at some point, no, you shouldn't be able to get help, and that's how that works. The next test is resource eligibility. This is the one where there's the biggest amount of misunderstanding, and that is for someone who's unmarried, the asset limit is only $2,000 countable, and then for a couple, an extra $137,400, so a total of $139,400. The reason that number is much bigger is because if there's a healthy younger spouse whose future is in jeopardy, we can't have her getting bankrupted by the cost of his care. Of course, my single clients think that's not fair, and my married clients say $130,000, that doesn't go anywhere near as far as it used to, that's not enough, that's too low. And so my normal husband and wife client might have $200,000 or $300,000 or $400,000 instead of $100,000, and my job is to help them understand where that could go, what they could do with that. The other thing to understand is that those are the numbers that apply to countable or non-exempt assets. It's beyond the scope of this conversation to start giving you ideas about how to plan, but I can tell you that the list of things that are exempt is extraordinary. In addition to your home and a vehicle of unlimited value, there are many other things that Georgia Medicaid considers exempt, and in certain circumstances, I will go so far as to say that can include retirement accounts. Okay? In other words, I have a client right now, his wife walked in my door and they were already eligible for him to apply for Medicaid. He used to be an executive at UPS. He has a $1 million 401k. Their house is worth $400,000, not even including their other assets. That's a net worth of $1.4 million, and they walked in my door. I'm not even doing anything to help them qualify. He's already eligible. So I highlight that point to make sure you don't make the assumption that Medicaid isn't for you or your family. Instead, it's important to get information, kind of like when you were in 3rd grade back when we had the projector with the overlay. Get somebody to put an overlay of Medicaid rules on top of your stuff to see where are you outside the rules and whether you could qualify at some point, because assuming that you can't could ultimately be a big mistake. And I'll never forget a particular client. She was sitting in my office sobbing because she had blown through $300,000 of her husband's retirement account that was exempt $300,000 ago. But nobody told her, and certainly the nursing home didn't tell her, because they wanted to get the big private paychecks. So definitely don't assume that you can't get help because you have to be destitute. We're almost through all the slides. This one relates to the transfer rules. Everybody here has heard of something called a look-back period, right? You guys know that, yeah, there's an asset limit, and also I can't just give it all to my kids today and say I'm poor tomorrow and apply and ask for help. Because it is so readily available online, I'm happy to share that the Medicaid look-back period is 5 years. How that is applied to any given particular transfer and what kind of penalty it can cause, again, beyond the scope of this, but the point is that that's how far back in the past they care about what you've been doing with your stuff. It's possible for a penalty to be more than 5 years if what was given away was more valuable than a 5-year penalty. And there's a formula they have to calculate that. Similarly, you could make a gift today and apply for Medicaid tomorrow, because the penalty they impose is a function of the size of the gift. So if you give $15 to the United Way today and apply for Medicaid tomorrow, it's not like you lose Medicaid forever. They're not even going to look at that. That is not for the tape a suggestion that somebody could give $15,000 to the United Way and it won't matter. It's the amount that I'm talking about. Speaking of $15,000, I am going to ask for a show of hands. How many people have heard of this government rule that says you can give $15,000 a year to all your kids and their spouses and so forth? Has anybody heard of that rule? Okay, 1 or 2. It was 10, 20 years ago, but it's gone up and up and up. It's now 15. That is a rule that exists within the Federal Estate and Gift Tax Code that applies to the wealthiest 1/4% of America. None of the rest of us, certainly me, maybe you guys have that much money. Right now, the limit is somewhere around, let's say, $23 million for a couple, 11.8, I think, for an individual, before you'll ever owe any estate or gift tax. So the idea that you don't want to pay income tax and then death tax is not applicable to 99.75% of America, because you don't have $23 million, right? Maybe you do, again, I don't know. Shouldn't assume. You wouldn't be here if you had that, though, so I kind of feel like I can assume. The point is, the fact that the IRS lets the extremely wealthy folks get rid of money to avoid tax, unfortunately, has nothing to do with my clients, who I don't want to call them the little people, but relatively they are. They're the people who have a home and a few $100,000. They're going to get hammered for those very same $15,000 gifts. So it's not uncommon for somebody to walk into my office and say, well, I've been giving these away because the government says I can. And then I have to say, unfortunately, the IRS, the fact that the IRS lets you do that for estate and gift tax purposes has nothing to do with Medicaid. So be careful about that. When she emails this out to you, you can review this. This is a list of things that are allowed and things that aren't allowed. And there are some pretty important exceptions to the general rule that you might want to take a look at, because there are times when you can make a gift today and apply for Medicaid tomorrow, but I'm trying to keep this short, so I'm going to go past that. This is a slide about the patient liability budget. I'm not going to spend a lot of time on it. Instead, I'm just going to speak more in general terms. if somebody's at home and on the community care program or in a nursing home and on Medicaid, the bill isn't just free because you're on Medicaid. Normally you still will have a cost share, it's just a lot less. It actually is possible for it to be free if a couple has income below, for CCSP, below about $4,000 a month. You actually will get all of that care and not be asked to pay for any of it. For someone who's in a nursing home, it's a little bit different than that, but again, if the couple has income of less than, let's say, $3,500, then it will be free, but otherwise there will be some modest cost share. So if you have to pay $800 a month instead of $8,000, that can be extremely valuable. This is just, again, you can look at this when you're at home, a sample of the patient liability budget for someone who's married, a couple, and then someone who's single. This $3,400 deduction is one of my favorite times of any meeting I have with a couple, because what that says is spouse at home whose income is very low, you're going to get to keep the first $3,435 of your marital income to live on, because Medicaid gets that you can't survive on your $885 check while his Social Security and pension go to the nursing home. So you are protected from an income standpoint, and if together as a couple your income is below that number, you get to keep it all, and your husband's bill is actually free. The last two slides, I think, myths. We talked about how Medicare and Medicaid aren't the same. Medicare doesn't pay for long-term care. It only covers for up to 100 days of post-hospital rehab. We talked about the quality of care shouldn't suffer if you ultimately go on Medicaid. VA long-term care benefits, the assumption is that they're only available to people who are 20-year servicemen or have a service-connected disability, and we talked about how the Wartime Pension says that's not accurate. For many years, the VA didn't have a look-back period, so a big part of what I have to share with people is they actually do have a look-back period now. It's 3 years, and it has a bunch of different rules from the Medicaid one. The point is, don't just go and give stuff away to try and get VA benefits. I talked about how Medicaid has a lot of exceptions to the transfer rules, so not every penalty gets subject to penalty. The second to last, you have to be bankrupt or destitute. We talked about that. The last one, Medicaid will take everything when I die. Who's heard about that? Estate recovery. That's something that, again, I'm trying to be efficient, but I know this is important, because a lot of times people will say, well, if they're going to just take my house after mom goes on Medicaid, then I'm not going to go on Medicaid. I'll keep mom home. Well, mom ends up getting inadequate care and falling and going to the hospital, and all because of this fear of estate recovery. So what I can say about estate recovery is, for a husband and wife, it's almost always possible to completely eliminate any estate recovery within Medicaid's rules. For the second spouse, or for someone who's unmarried, estate recovery is not the bugaboo that it sounds like. And the reason is that there are various planning options to minimize the bite of estate recovery. And worst case, Medicaid payback happens at the discounted rate, the Medicaid rate versus the private pay rate. So that can translate to thousands of dollars of savings over time as well. I think I'm just going to pass on this and go to questions. If anyone wants to email me about any of these, you're welcome to. If there are any questions, I'm happy to answer them. Yes, ma'am.
Can we get your business cards?
Yeah.
And also, what services do you provide? What will we come to you for?
Thank you for asking, and I didn't pay her to ask that or anything. So my firm is very narrowly focused on what we just talked about. There are estate planning attorneys who do wills and trusts and help with probate and guardianship, and there's some excellent ones right around here. If you need one, I can help you find one. But I don't do just simple wills or even complex, tax planning, because I stay really busy at what I do and I try to stay in my lane. So people who have questions about this type of planning, a corollary is something called special needs planning. That's when somebody is disabled and wants to qualify for a government benefit or needs to qualify for a government benefit. That's an entire separate area of law, but it overlaps with mine because it's very common for someone who's widowed and 85 who needs a nursing home to have a 58-year-old son with autism that she's terrified about what's going to happen to him when she's gone. One of the things on this list is transfers to a blind or disabled child or transfers to a trust for any child who's disabled. So the point is, I can establish a special needs trust for mom for the benefit of her disabled child and turn on Medicaid instantly without any penalty for her, because where her money went when it left her name to reduce her net worth, where it went is a permissible donee, a trust for her disabled child. So that's where there's some overlap. Yes, I'll leave some cards, and if you have questions about any of these topics we talked about today, that's probably why you would call. If you ever do, the way I handle things is my assistant will do what we call a discovery call. There's no fee for that time. She'll populate a bunch of information about health and income and assets and transfers, and that typically takes her a good half hour. I can look at that in 30 seconds and figure out, do these folks need help, and am I a good fit for them, or maybe do they need some other type of professional? So if you think that there might be something I might be able to do to help, I'm glad to try and help if I can. Does that answer your question?
Well, I guess to sum up, there's some instances where you can help in planning, and then other instances where now you've been all of a sudden got some kind of health thing going on, and it's not like an emergency kind of thing, right? So you can help in both planning.
Actually, that's a brilliant point, because you've just identified the two types of planning that an elder care attorney can do: preemptive long-term care planning versus crisis mode. Preemptive is for typically clients who are younger and healthier and more financially secure and maybe even have long-term care insurance. They can intentionally step outside the Medicaid rules and settle an irrevocable trust, or do things, give things away that is against the rules. And the reason is, cuff me for 5 years. I don't care, because I don't expect to need Medicaid for 5 years. So that type of planning exists. It's actually more rare, because how many of us have that much vision to think about when we're going to need nursing care? Or, people just don't like thinking about that. So it's a little rare. The majority of my caseload is the crisis, what you just said, and believe it or not, those are the easy cases for me, because I know what the law is today and I know what my client's financial picture is today. The harder cases are the ones where someone says, well, mom's in assisted living, she's been deteriorating, she doesn't need a nursing home today, we're not in crisis, but I don't really feel all that confident about 5 whole years before she might need to ask Medicaid for help. And even in those situations, I'll typically meet with a family. We'll rule out preemptive planning because we can't wait 5 years. But in terms of do's and don'ts, there are definitely things that clients should do and things that they shouldn't do while waiting to see if crisis mode ever hits. You can't plan today and apply for Medicaid today for somebody who isn't in a Medicaid participating facility, though. So you can't get all your ducks in a row and file for Medicaid. Why that's relevant is because the law changes. Every 3 months in Georgia and in Washington, whenever they feel like it, Medicaid eligibility rules change. And so implementing a crisis mode plan when you're not in crisis can be precarious, because they might pull the rug out from under you because things that were done based on the law in 2022 that was permissible or were permissible aren't permissible anymore. So 3 years later, when you file for Medicaid and say, well, Dan said we could do this, they're going to laugh and say, well, what you could do 3 years ago has nothing to do with the law today. And so, but yes, there's such a thing as crisis mode planning, and that's actually the easiest type of case for me if anyone's ever facing that. Did that answer your question? Mm-hmm. Okay. Yes, sir.
Yeah, I have a long-term care policy, and recently got literature from them seeking to buy out the policy. That's never happened before. Or the other option is to raise the monthly cost. And in the explanation letter, they had stated, and I don't know what the numbers are, but that a great majority of the long-term care companies are no longer in business because of suffering losses, et cetera. Is that pretty much valid, you think?
So the current health of the long-term care insurance industry, it has undergone, they basically gave themselves a black eye. But this was back in the 90s,
Yeah.
at the beginning of this, cottage industry within all of insurance. Now, 6 or 8 companies, Mutual of Omaha, MetLife, Genworth, John Hancock, Mass Mutual, there are some big, you guys might remember the phrase too big to fail. There are some big insurance companies that own the vast majority of the long-term care insurance industry. Was one of those companies yours?
No, mine is,
Can't remember. I pay him every month.
Transamerica.
Okay, that's another big company.
Yeah.
So the point is that there are now companies, your rates have gone up over time.
Oh, they have.
Okay, if you have a monthly or annual premium, they've been going up, and that the part about buying out I've never heard, but yes, it's very common for them to go back to people and say, look, the insurance commissioner says we're allowed based on a book of business. They can't pick on you and say, oh, we see you got a medical diagnosis, we're going to raise your rate. They're not allowed to do that. But they can go to the state of Georgia insurance commissioner and say, for all people in the age range of 65 to 69, we're losing money. We need your permission to increase the premium for all of them by 3.4% in order to keep doing business in Georgia. If you want us to keep doing business there, you have to give us permission, and then they do. Then you get that letter. So it is very common for those letters to happen, but the companies that have gone out of business don't exist anymore. Transamerica and these other ones, I wouldn't be especially concerned about them necessarily going out of business. You just have to decide if you want to go with the increased rate. Sometimes they'll let you reduce the daily rate of benefit to keep the same premium. You'll just have to crunch the numbers for yourself. Any other questions? Yes, sir.
We've got a long-term care with Genworth, and I read an article recently that the U.S. Congress is concerned about what he raised was the financial stability of these companies. And so they were thinking about, they're looking at legislation that would cover. So the question I had was, let's say you do have long-term care and the company does go bankrupt for whatever reason, what happens to your policy at that point? Is there any kind of federal or state
Too bad.
backup?
Yeah,
thing, or is it just
not that I know
all your
of.
money is just gone?
Not that I know of.
It's just gone.
Which is not that you're going to change your overall plan, but which is why these hybrid products are now, among other things, more popular. It used to be that you would buy long-term care insurance, and then you had the use it or lose it problem. If you die and you never used it, your money's gone. So they created what's called the return of premium rider, which is you could name a death beneficiary, basically convert it into a life insurance policy where if you pay $100,000 in premiums and then die but haven't used any of it, then somebody gets repaid. That's a really old school thing. Now we have these hybrid products where it's not a long-term care insurance policy with a death beneficiary. It's a life insurance policy or an annuity with a long-term care insurance rider where you own an asset with a dollar value and a balance and you get a monthly statement on it. And if at some point you need to tap into it for purposes of long-term care, there is an enhanced value. So if your annuity is worth $100,000, you might have a $200,000 pool of money from a long-term care insurance standpoint. These policies have been, or investment products have been a big reason or a big way that people choose to stay away from the risk of the company going out of business. Genworth is like the biggest one there is, so I don't know, you can decide for yourself how concerned you are about it, but There's no FDIC type thing that I'm aware of for long-term care insurance. We're kind of going over, but again, if I'm happy to stay if there are any other questions. Otherwise, I really appreciate the chance to be here, and I'll leave some cards.
Coming. Absolutely, I appreciate you coming. We'll stop the recording, but as he said, he's available for if you have a question.